So you have any signs and symptoms every 5 minutes. It changes, right? Remember we talked about that before. So this is how we apply it. We learned all that stuff way back in fall. This is how we apply it for our patient. Get screened frequently so that you are trying to prevent developing this cancer, or at least trying to identify it early. What do we say about colon cancer? Is it fast growing or slow? Slow. It's slow. So what that means is, if you can find it early, you have a good chance of recovering from it. Other types of cancer are fast growing. Certain types of brain tumors are fast growing. By the time you find them, within a couple months, the patient has usually got a lot of symptoms and possibly even mortality dead, from the brain cancer. Just depends on the type. Don't give yourself brain cancers every time you have a headache now that you're a nurse, because that's what you'll do the rest of your life, right? Anytime you have bowel pain, you'll think you have an obstruction, because that's what you know about. That's what we do as nurses. So just recognize that signs and symptoms are here, and it's for us to identify and figure out what is our next step for this patient. So the patient with colon cancer, basically cancer is what? Cells grow out of control. Abnormal growth of cells is what causes cancer. The cells that should not be growing and are abnormal grow quickly. What do you think our treatment for colon cancer would be? If we recognize it's in your large intestine and we identify that you have colon cancer, aren't we going to want to see where it is? How big is the tumor? Can we do surgery to take it out? Yes, we can. There's that patient that now might end up with a colostomy, but their chances of survival are good if we get rid of the cancer. Can we do chemotherapy for somebody with colon cancer? Yes, we can. Why would we do chemotherapy for this patient? Well, what we want to figure out first, is the cancer just contained to the colon itself, or has it spread anywhere else? And if it's spread somewhere else, that's when we get chemo. If it's just contained to the large intestine and we can remove it, the patient might only need surgery. I don't say it only like it's not a big deal, but surgery might be enough to get rid of the cancer, and then we would just continue to monitor the patient. What kind of labs do you think we would get, or we would anticipate getting for this patient to determine if they have colon cancer? What kind of diagnostic test? Colonoscopy first, right? What can we do before the colonoscopy? What about that fecal occult blood? Now, it's really recommended that at age 50, everybody does that every year. Trust me when I tell you, hardly anybody does that every year. But that might be a recommendation from your doctor to start there. Fecal occult blood. How many of them do we need in order to say the patient actually has stool? 3. How many people do you think are compliant with taking 3 stool samples to the lab? Hardly anybody, right? So we go to the colonoscopy and we say, hey, at least get this done. We can identify that you have polyps. If you have polyps, we want you to come back sooner than 10 years, 3 years, 5 years, right? Because you have polyps, and polyps can develop into cancer. Okay, and we talked about colonoscopies before. So again, look how prevalent it is. The second most prevalent cancer in the United States, internal cancer. What do you think the first one is? Breast cancer. Breast cancer, yeah. But colon cancer is pretty significant. It's a pretty high number. What are some things in your diet that make you more likely to develop colon cancer? Things that we eat. Fatty foods, red meats. Have you heard before we recommend to people eat fruits and vegetables to slow down your risk of colon cancer? Have you ever heard that before? Better diet is obviously going to decrease your risk. So red meats, fatty foods, right? These are the things that we would say, hey, is this all you eat all the time? What about your genetic history? Doesn't that create more likelihood that you're going to develop colon cancer if you know your mom or dad had it? Yes, there's a genetic link to certain types of colon cancer. So we got to think about what are our risk factors for this person to develop colon cancer. And colorectal cancer is the same exact thing as colon cancer. It just depends on whether it's cancer. And it can affect the large intestine, it can affect the sigmoid intestine, that's the part connecting the colon to the anal area. It could be anal cancer, it could be any part of that lower large intestine. So these are the things that we would test that we would get. Might get a sigmoidoscopy if we only think it's in the sigmoid, more than likely to get colonoscopy or stool for blood, and then we could do chemo or radiation or surgery depending on how extensive the cancer is. Again, these are just types of surgery. A hemicolectomy would be heme in half, we remove part of that large intestine and then we put a colostomy in. Again, this would be a surgeon that was doing this surgery, removing the section of the bowel that has cancer. How are we going to know if the patient has signs and symptoms of colon cancer? We haven't talked about cancer yet, but there are 7 warning signs of cancer. You will know them before you get here. The very first one, if you write down the 7 warning signs of cancer, the word is caution. C-A-U-T-I-O-N. Anybody ever seen that or heard that before? What's the very first one? C. What's it stand for? Change in what? Change in bowel or bladder. That's the C. For caution. Write it down, Joel. You're looking at me. Okay, keep typing. C. Caution. Change in bowel or bladder. Change in bowel is an indication for colon cancer. What does that mean by change in bowel? Well, everybody knows what their normal bowel pattern is, right? Once a day, I go in the morning, or I go at nighttime, or I usually go twice a day, or I usually go every 3 days. Everybody has a different pattern. So if all of a sudden this person notices that I had diarrhea today, and I've had it for the last 10 days, and I don't know why, and we did an H. pylori, and we did a C. diff, and nothing's coming back, what do we start thinking? That's a change in their bowel. Did you change your diet? No, I'm eating the same stuff I've been eating. That's a change in bowel. Or all of a sudden the patient goes to the doctor and says, I haven't been able to go to the bathroom in 5 days. I don't know why. I have abdominal tenderness and I have pain and I have a change in my bowel pattern. Okay, this is one of those symptoms. Change in bowel or bladder is a sign. Change in bowel is a sign of colon cancer. Blood in the stool. There it is. That's fecal occult blood. If the patient sees blood in their stool, that's never going to be normal. Unless the patient has external hemorrhoids or something that can create that blood, right? So, again, blood in the stool needs to be evaluated. So you check it out. That could be the one sign that saves the patient's life. Everybody with me? Because this will be what you hear from patients, or you see when you're putting your patient on the bedside thermometer and getting them back from the bathroom. There's blood in that stool. Report that to somebody. It's not normal. We shouldn't have blood when we go to the bathroom. So that could be the one sign the patient could say, oh, I've had that for a while. I didn't know to get it checked out, or I don't want to go to the doctor again. Well, this could be the one thing that saves your life. Because colon cancer is slow, and if we fix it and identify it early, the patient can survive. So there's your change in bowel habits. That's your caution. That's your C letter of the word caution. Feeling of incomplete evacuation of bowel, meaning that the patient feels like they have to go, but they really aren't going normal. Now, narrow stools, there it is again. Those ribbon-like stools where they're still going to the bathroom. What do you think creates those narrow ribbon-like stools? A tumor being there that the patient still feels like they need to go, but they can't fully go around where that tumor is located. Everybody got the picture of what that looks like? Generalized abdominal discomfort, they're losing weight, they feel tired, they might be thrown up. Here's our signs and symptoms. Usually it's the change in bowel habits and blood in their stool that the patient's going to tell you all about, right? Or you're going to see it. That's not going to be normal for that patient. So you might need to do surgery, you might need to do chemo, you might need radiation, you might need all treatments depending on how extensive colon cancer is. I've had patients that I take care of in the 20s and 30s that have died from colon cancer. That's young. That's the patient that by the time they notice the symptoms or they think they're 25, I don't want to go get a colonoscopy, or I know it's in my family history yet. I noticed a change in my bowel pattern, but I really didn't think it was that big of a deal. Okay, now they have massive symptoms. By the time we recognize all of the symptoms and put it all together, that colon cancer is spread throughout their large intestine. And we can't always fix it. So colon cancer can be deadly, but it can also be curable if we find it early. Okay? So again, here's what we do to tell our patient, and NCLEX loves this stuff because they want to know that you guys can educate the patient. That's what the first thing we want to do. Get screened regularly, so that's your colonoscopy, that's your stool blood. Maintain a healthy weight throughout your life. Well, we all try to do that, but some are better than others. What's that mean? Keep your BMI below what? 30. right? That's the obese number that we're looking for. We don't want to get there. Stay physically active. What the heck does that mean? At least exercise. So that lowers your risk of colon cancer. Exercising and staying active and not being obese and sedentary. That's going to increase your risk. Consume a healthy diet. Emphasis on plant sources. Here it is, what we just talked about. Eat fruits and vegetables. Some people don't like that stuff. Some people like the fast food and hamburgers and the red meat. They don't like vegetables and fruits. Lots of people don't like to eat that stuff. Well, this is something that maybe you need to modify and at least have some of this in your diet. Less red meat and processed meat. Eat at least 2.5 cups of vegetables and fruit every day. Think about your diet right now. Do you eat 2.5 cups of fruits and vegetables every day? No. Who does, right? Not everybody. Some people like salads. I like salads. I like fruits and vegetables. But do I also tonight, Ken's already like, let's have Chinese tomorrow night because he loves Chinese food. Do you think that's good on my diet all the time? No. Right? So you got to make sure at least some moderation. This is what's recommended. So this would be your select all that apply. 2 to 3 cups of fruits and vegetables every day. Not everybody likes this stuff or wants to eat it or fix it in their diet. Whole grains is good for that patient. If you drink alcohol, limit consumption. There it is again. Alcohol is a risk factor. Drinking alcohol, higher risk factor for colon cancer. Consume the recommended levels of calcium and then obviously avoid smoking. So how are we going to identify what's our patient's risk factors for colon cancer? Or are we going to ask them, well, what's your weight? Let's get their weight. Do you exercise at all? Tell me what your diet is like. Do you smoke at all? Do you have a family history of colon cancer? Okay, well, my mom or dad had colon cancer in their 40s. Well, doesn't that make me more likely to have it? African American, higher risk for colon cancer. It's a hereditary link. It's there. It's nothing you can change, but you just have to be aware of it and recognize that this is one more risk factor for the patient, and they need to get screened regularly, like we recommend. Abnormal growth polyps, this is telling you what polyps are. Basically, polyps are abnormal tissue that can turn into cancer over time. So here's our risk factors again, things we can change, things we can't change, recognize there's some things that are modifiable, some things that aren't. As we age, we can't change that. I'm over 50, 90% of colon cancers happen over the age of 50. So what does that mean? Well, I should get screened. I should get a colonoscopy, right? I should get that every 10 years. If I know that my dad was diagnosed with it, doesn't that give me another risk factor? If I know that I eat a lot of red meat, do I have another risk factor? If I know that I smoke, which I don't, is that another risk factor? I tried to smoke one time, my mom made me eat the cigarette and never smoke again. So it worked. So here's our risk. Here's our links. So what we say is going to make the patient more likely. Look at diabetes. Can I fix that? Well, I can maintain my sugar where it's supposed to be. Look at the risk for diabetes. 30 to 40% increased risk of developing colon cancer. That's a lot. That's a lot. So manage your diabetes. Can you modify that? Yes, you can. Smoking, alcohol, all the things that we can change, let's change and keep us healthy as we can. Other risk factors, and we're going to talk about inflammatory diabetes, a family history of colon cancer, lack of physical activity, low fruit and vegetable intake. Again, overweight, obese, consuming alcohol, high-fat diet, they're all listed here, things that make us more likely to develop colon cancer. There's our symptoms. Blood in your stool, and you have a bowel movement, stomach pain, cramps that don't go away, losing weight, and you don't know why. You have some kind of cancer. Here's our screening guidelines, starting at age 50, colonoscopy, and then as a doctor prescribes from there, usually every 10 years. Again, if you have history or you have other risk factors, I might even recommend every 5 years, just based on the fact that your family had it, you're over 50, or you smoke, or whatever your risk factors are. If you have a lot of that, then the doctor might recommend it more frequently than 10 years. Again, second leading cause of cancer-related deaths, so that's a lot. It's a lot in the United States. Okay, we talked about esophageal issues, and then you can get cancer of your esophagus. I think we went over that yesterday. Cancer of the stomach is obviously called gastric cancer. Most of the time it's located in the pylorus, which is at the top part of the stomach. And again, what could we do? Well, when we do a gastrectomy, what if we do a gastrectomy and take out the patient's stomach because they have stomach cancer? Now, what do we have to think about? Nutrition. How are we going to feed them? What kind of tube are they now going to need to have in order to feed them because we took out their stomach? And this is just talking about stomach cancer. Most of the patients I've ever taken care of with stomach cancer, they don't have a lot of signs and symptoms till it's really pretty advanced. And many times we have to take out the entire stomach in order to keep the patient healthy. When somebody has cancer, like in the colon or stomach or some local area, what are we worried about more than that local area? Has it spread anywhere else? And how do we figure that out? By further testing, PET scan, CAT scans, other things. So again, we can treat stomach cancer if we catch it early. May not only look at how many different things create abdominal pain, right? I mean, we've all had stomach pain before, a virus, something you ate, food poisoning. So look, they have vague epigastric pain and they don't know that it's stomach cancer, and they really don't get it checked out for a while. So again, it's just recognizing what are risk factors, what kind of tests can we do to determine. But what else is going along with it? Well, they're losing weight, they're not eating, right? I've noticed that I've lost 20 pounds in the last 2 months. There's something going on. I lost 1 pound. I figure out what it is that's happening with that patient. So here are some tests that we might do in order to look at stomach cancer. GI signs, that's just drinking that berry or taking some pictures. They might need that endoscope test done to go down and look at their stomach and see if we see a tumor or do a biopsy. They might get a hemoglobin and hematocrit because their stomach cancer might cause some bleeding in their stomach. Again, we might probably need to do surgery. What happens if we take your stomach out? What kind of anemia do we have to think about? Somebody said pernicious. So look at the story. If it says the patient had a gastrectomy for stomach cancer, now what are they not doing? They're not making intrinsic factor. They're not absorbing B12. They become pernicious anemia. Okay, it all goes together. So now they get injections instead of taking B12 in the diet because they most of the time don't get enough in the diet. Okay, inflammatory bowel disorders. Here they are. Here's our next section. You gotta keep going. Okay, stretch. Whatever you gotta do. Yep, caution. Change of bowel bladder. A sore that does not heal. Trying to remember it off the top of my head because it's not on here. Unusual lump or thickening. What's T? No. Change of bowel bladder. Change of bowel bladder. A sore that does not heal. Unusual discharge, unusual discharge. T, thickening or lump. I think is indigestion or difficulty swallowing. I have to look it up. O is
obvious
change in wart or mold. Yep. And N is nagging cough or hoarseness, I think. Is that right?
Yes.
I'm pretty amazed that I remember learning this in nursing school a long time ago. That's the word caution. And that's our signs of cancer. Now this next test won't have cancer on it, but look how that very first sign has to do with colon cancer. Right? Change in bowel bladder. Okay, so here's our inflammatory bowel disorders. Well, what do you think that means? Inflammation. All these disorders here are some kind of inflammation. Look how they end in itis. You know what that means, right? Inflammation. So Crohn's disease is an inflammatory bowel disorder. Most of the small intestines kind of diffuse inflammation throughout. Ulcerative colitis, we'll talk about it. It mostly affects the colon, the large intestine. Diverticulitis, what is that? That's inflammation of the diverticuli, little pouches that are in your large intestine. And we'll talk about what that is. Appendicitis, what is that? That's inflammation of our appendix. And what do we do for that? Usually surgery and take it out. Gastroenteritis. What is that? Inflammation of our gastric area and upper bowel from viruses, H. pylori, whatever. That is similar to gastritis. Peritonitis, what is that? Inflammation of the peritoneal cavity itself. Okay, so here's our inflammatory bowel disorders. There's a chapter on them in here. It talks about them a little more than what we're going to talk about in here. But because we know it's inflammation, all of these disorders, what do you think is going to be elevated if the patient has peritonitis? What kind of labs are going to be elevated? Let's start with our CBC. Where's our white blood cell going to be? Up. Isn't there inflammation? Isn't that one of the things that elevates our white blood cell? Infection or inflammation? Two things. Infection or inflammation. Put that in your head. It elevates our white blood cell. What about our SED rate? What happens with that? That ESR number. Does it go up or down with inflammation?
More than 20.
Above what?
20.
SED rate is less than 20. Everybody with me? You've heard this stuff before, right? We're trying to remember it. So we're going to anticipate SED rate's going to be up. We're going to anticipate the WBC number is going to be up. There's something called C-reactive protein, CRP. That's a protein that reacts when you have inflammation in your body. That's going to be up. What about our hemoglobin and hematic rate if the patient has inflammation and have blood in their stool? Where does that go? Up or down? Down. The patient is bleeding. It's going to go down. What about our red blood cell number? Where's that going? Up or down? Down. So you have to think about where's this stuff going? What are the numbers? What would we anticipate? What would be our star cell that apply if we got the patient with ulcerative colitis? Where's all of our labs going to be? What would we anticipate the doctor would order in order to determine what's happening with the patient? Now, what other kind of tests do we have to get in order to figure out you have Crohn's or ulcerative colitis? CAT scans, right? Some kind of x-ray or something, most of the time symptom-based, and then we get some diagnostic testing. And tell me, how many stools have you had? How long has this been lasting? Where's your pain at? And then we need to get a CAT scan draft. We need to do an upper GI test or a lower GI test. Maybe with Crohn's, we found it doing a colonoscopy, and we found large inflammation in inflammatory areas. Colonoscopy can determine if a patient has diverticulitis. They can see the diverticuli, and then we put the scope in and take the pictures, and now we determine diverticulitis. And might need to have surgery to have that fixed. So I'm just trying to help us think about these disorders. What kind of pain does a patient have if they have appendicitis? Where is it? Right lower quadrant. What about, do they have rebound tenderness? Most of the time, yes. What other symptoms do they have with appendicitis? Nausea, pain, tenderness, right? They feel generally lousy. Their temperature may go up. Their white blood cell count goes up. That's the stuff we're looking at. And anybody that comes in with right lower quadrant abdominal pain, and we get a white blood cell count of 18,000, immediately we're thinking, okay, their appendix probably needs to come out. Sometimes they even take the patient to surgery even without the CAT scan. They don't even need the CAT scan. They just know that that's what's happening with the patient, and we're just going to take your appendix out because it really doesn't do much for you anyway. So the worst thing is to leave it in there and now the patient becomes severely sick and the appendix rupture. So we'll talk about appendicitis a little bit and these other things that are listed here. So because we know it's inflammation, these inflammatory disorders, wouldn't we want to pick steroids for these people? So people that have Crohn's and ulcerative colitis and diverticulitis, it's inflammation. Steroids are good for that. Steroids help decrease the inflammation. Do steroids have side effects? Yes, they do. The patient gains weight most of the time. The patient feels hungry. The patient's blood sugar goes up. The patient has trouble sleeping. What do steroids make you feel like? Mentally anxious, irritable, right? Remember all the side effects that we talked about steroids. So yes, they're good to treat this stuff, but we have to think about the side effects. If the patient has a fungal infection causing peritonitis, wouldn't we use fungal medications? If the patient has lots and lots of diarrhea from having Crohn's, we might have to give them anti-diarrhea medications like Imodium. Anybody ever heard of Imodium? That slows down the diarrhea slows in half. What are we thinking if the patient has 10, 12 loose stools per day? What should we be thinking? Fluid volume deficit or fluid volume overload? Deficit. Makes sense, right? And now they're going to become dehydrated. So we should be thinking IV fluids, lots of PO fluids by mouth, anti-diarrheal medications to try to slow that down. Anything that we can do to try to keep the volume within the patient. And how are they going to feel? Weak, tired? What happens when they get dehydrated because they have ulcerative colitis and they had 20 loose stools today? What's their vital signs going to look like? Heart rate's going to go up, right? That's dehydration. Blood pressure's going to go down. Respiratory rate's going to go up. Their temperature's going to go up a little bit, right? So none of this changes. It's just this is the reason for the fluid volume deficit. Everybody understanding that, where we're going with this. So here's your meds that you might use for the patient. You might have to do surgery. People with diverticulitis that have severe inflammation in their colon sometimes have to have part of that colon removed. If it's affecting their ileum, look what they end up having, an ileostomy. Because now the Crohn's disease is so bad in the small intestine, it's not going to get better unless we remove that part of the small intestine. So when I worked on 5D at Christiana, we would have people with diverticulitis, and they could come in to the hospital with signs and symptoms, and it would be diarrhea and abdominal pain and nausea. And we might be able to rest their bowel for 2 or 3 days and they get better. But then you might see them again 6 or 8 months later, and the diverticulitis flared up again. Okay, now we rest their bowel a little bit, and then 6 or 8 months later, here they are back again. So now you have a third admission within a year and a half. Now, guess what the doctors want to do? Surgery. So kind of like medical treatment first. Trying to manage what your diet is, manage your symptoms, to put you on steroids. Okay, that's not working. Now we move on to surgery. So it's not always the first choice, but sometimes it is a choice. And here's our labs that we're going to get for the patient. So appendicitis. That's inflammation, obviously, of your appendix. Where's your appendix located? Right lower quadrant. Signs and symptoms come on quickly. What age group is more likely to have appendicitis? Young adults, adolescents, most of the time. So there's my 15-year-old. There's my 13-year-old. There's my other 15-year-old. I told you, 3 of my kids have had their appendix up. They still have it, but they were all teenagers when this happened. So young adult and adolescent, more likely to be in that category. Why? I don't know. But they're the ones that typically show up. Younger people with that. Now, can older people have appendicitis? Sure. It can happen anywhere, but usually it's like younger person. Pain around the belly button is sometimes one of the symptoms. Maybe generalized abdominal pain, but what they do have is rebound tenderness. You might have a temperature, you might be throwing up. What happens when their appendix ruptures? You remember me saying they kind of get a little bit better for a short period of time, and then they get worse. So that ruptured appendix got rid of that pain and pressure that was there, and that appendix getting bigger, but then maybe 12 hours later they really feel sick, because now their appendix is ruptured and it's starting to develop inflammation in the whole area around their appendix. There's nothing that we're going to do medically to treat appendicitis. Always pick your option is surgery. You can't fix it. If that's what they had, you can't send them home and say, here, drink some fluids, it's going to go away. It doesn't go away. They're MPO. One thing to remember, you don't put heat on them. You don't put a hot pack on their stomach. They're not told to go lay down in the hot bath. What happens is when you put heat on their stomach, it causes the appendix to rupture. So cold is what you're going to use. So when you think your family member thinks you're a nurse and you might have ruptured appendix or appendicitis, don't tell them to put heat on it, because they're going to expect you to know everything. Tell them to go to the doctor immediately, because they're probably going to need to have their appendix out. And you want to get there before the appendix ruptures. One other thing in ATI you're going to see, and you might get it as a question on NCLEX, never give an enema. Why? What is happening in your lower abdomen if you have appendicitis? Isn't there tenderness? Isn't there inflammation? Probably inflammation all around your lower bowel. The patient might get constipated because they have all this inflammation going on. Don't give them an enema, because you inserting that enema creates more pressure in that lower bowel and can cause the appendix to rupture. So no heat, no enema, surgery right away. Why don't we want to give them pain meds right away until we figure out that that's your diagnosis? What if you come in with abdominal pain and I just decide to give you 4 milligrams of morphine because I want you to feel happy and make your pain go away? What are you doing with the pain medication? You're masking the symptoms. Everybody with me? So we need to figure out what's happening and you come in right now, let's say 2 o'clock this afternoon, hopefully if Christiana can see you, they're gonna have you inserted by 4 o'clock. It's a pretty quick, like, this is what they need to take in surgery. So we don't wanna mask the symptoms and have the patient laying there for hours saying, oh, well, my pain went away. What's gonna happen in the meantime? The appendix is gonna rupture, okay? So no pain medications, so don't pick that, even though we all think, okay, Maslow's hierarchy says give them pain meds, not with this patient. No heat, no enema, no pain meds, until we know for sure. And how would we know for sure? What if we sent you for a CAT scan and we know that you have appendicitis, but the OR is not going to be ready for 4 hours? Then we can give you pain meds. Does that make sense? We've got your diagnosis. We're not going to make your pain go away and then hope for the best. So we need to figure out what's happening. This is what we're going to do for this patient. Everybody okay with appendicitis? I know it's only one slide, but I know there's ATI questions on it. Okay, peritonitis, what is it? Inflammation of the peritoneal cavity.
Ms. Anderson?
Caused by leakage of content around the abdominal cavity. It could be caused by appendicitis. Could be from that perforated duodenal ulcer, wherever it's located. It could be diverticulitis. Could be a bowel perforation. Any of these things can create peritonitis. What is acute salpingitis? Basically, your ovary, an ovarian infection, inflammation. The tubes themselves are inflamed. That's salpingo. If you say salpingo oophorectomy, we're taking out both of your ovaries and your tubes. So that's a GYN issue. That's a female issue. Trauma to the stomach, couldn't that create peritonitis? Or if you're stabbed or you fell or you landed on a fence or you inhaled yourself with something. What is CAPD? What's that stand for?
Central Auditory Process.
Stretch, wake up. What's CAPD? Stand up if you need to.
Central Auditory Processing Disorder.
Nope. Continuous ambulatory peritoneal dialysis. That is CAPD is your peritoneal dialysis patient. Anybody know what peritoneal dialysis is? So hemodialysis is you're hooked to a machine and the machine is doing all the dialysis for you. You have that fistula, there's one artery, one vein, goes to the machine does all the dialysis. Peritoneal dialysis is the catheter is inserted into your peritoneum and the dialysis exchanges are like bags. And I'll show you what a picture of that looks like. So 2 ways of doing dialysis. We'll talk about this in the very next section of stuff that we're doing renal. But peritoneal dialysis, think about what it is. We have a catheter into your peritoneum that does the dialysis for you. It dwells in your stomach for a little bit and then it gets drained back out, and it'll make more sense when we talk about peritoneal dialysis. But the fact that we have a catheter in your stomach, doesn't that put you at risk for peritonitis? Couldn't it get infected? So that's why that's listed on here. So here's all the things that can create peritonitis. Inflammation of the peritoneal cavity. And all these things are listed here. There's your pain again, that rigid abdomen, hard, right down tenderness. Your temperature's going to be up. Your heart rate's going to be up. Your white blood cells going to be up. What do we have to do to treat this? Look at what our treatment is. Lots and lots of antibiotics. So the patient has an infection all in their stomach area. It's not just one specific spot, but the whole peritoneum area is infected. What's going to happen to them? They're going to get septic and die if we don't treat it. So peritonitis is a big deal. That's why I say, if the patient has a perforated bowel, we got to get a treatment pretty quick, because this is what's going to create their issue. This is what's going to kill them, is getting this inflammation around their bowel cell. Gastroenteritis is just that, basically. The gastric and enteral area, the feeding area, is inflamed and infected. It could be bacteria, could be hepatitis A that we picked up from a fecal infection. Long-term antibiotic use, what does that create? C. diff. Remember, put that in the picture. The patient's been on antibiotics for 2 weeks and now they have diarrhea. I should suspect C. diff, and that can create what's called gastroenteritis. So basically, it's just inflammation in the gastric area and the enteral area, the bleeding area, that small intestine. So again, eliminate the cause. Figure out where it is. Look creative. If it's H. pylori, antibiotics. If it's C. diff, give them antibiotics to treat the C. diff. If it's a viral infection, treat the symptoms, right? And give them supportive care. If it's because they're bleeding and then they have gastritis, well, you might need to give them blood. Whatever it is, you need to figure out what the cause is and then treat the cause and obviously treat the symptoms for the patient. Here's some other causes of gastritis. We talked about this just yesterday. H. pylori is a common cause. Certain aspirin, certain medications, steroids can actually cause gastritis if people take them too long. NSAIDs, spicy food, smoking, all this stuff we talked about yesterday. And this is just some different medications that we might use. What's an antiemetic that we're going to pick for the patient? It starts with an O. We know the name is Zofran. What's again? It's called ondansetron. That's Zofran. That's an antiemetic. So when you see it and it has an O, that's a medicine for nausea that we give patients. You can give Zofran as a pill. You can give it IV. You can give it under people's tongues. And it gets absorbed quick that way. So here's acute gastritis, gastroenteritis, kind of means the same thing. Figure out what the cause is. Try to eliminate the cause. Treat the symptoms. What are you going to recommend for this person that has gastroenteritis as far as a diet? Do they need to be NPO or not? No. What have you ever been if you had gastritis or your stomach was inflamed or irritated? Were you NPO? What did you want to take?
Ginger.
Didn't you want to drink fluids? What about bland foods? Wouldn't we want to pick that for the patient? Right? Just think about what's happening with the patient. No spicy foods, not a lot of solid food right away, just small, frequent meals. Increase your fluid intake, whatever it is, so that you can try to keep yourself from being dehydrated. And treat the symptoms, and then start advancing your diet. And again, here's some of our signs and symptoms if the patient has an infection or what's going on. And again, all we need to do is look at the story and figure out what's the cause, and then figure out what kind of treatment will we do if we know what the cause is for that patient. Okay, irritable bowel syndrome. Anybody ever heard of that? Anybody know somebody that has that? Right? What is it? Irritable bowel is just that. Your bowel is irritated. What happens with irritable bowel? It can be one of two things. It can be constipation, it can be diarrhea, it can go back and forth. Irritable bowel is one of those things that it's not just always constipation. It's not just always diarrhea. What are some things that trigger it? Stress, lack of sleep, your diet, right? And it all kind of sounds similar to other things, but how do we diagnose somebody with irritable bowel? What do you think? Symptoms. Most of the time, symptoms. This is the patient that says, oh my gosh, I have a test coming up and now I have diarrhea. I went 4 times yesterday. That's irritable bowel. Or I ate this, whatever it might be that you know triggers it. Milk products, lactose products, cheese, things in your diet that you know trigger these symptoms. That's basically how you diagnose it. Because what we find out is there's really nothing physical that we can say is wrong with your bowel. It's just irritated by certain things that are triggers for you, right? How do we treat irritable bowel? Many times it's avoid the triggers that cause that to happen. Can we put this person on H2 medications and antacids? Sure, to treat the symptoms that they have. So it's different than reflux. It's basically their bowel is irritated. Most of the time, it affects the small intestine. So here's your symptoms. Frequent bowel movements, maybe that they're constipated, and then 4 days later they have diarrhea. It kind of goes back and forth. They might have a lot of gas. Look, and constipation and or diarrhea. So it's kind of a picture of irritated bowels. That's exactly what it is. Frequent bowel movements, feel like they need to go to the bathroom, but they can't. Again, pain in their stomach. It's basically an episode of alteration in the bowel function. Here's some medications and here's some tests that you can kind of do. Most of the time, it's symptom based. So tell me what your symptoms are, but look at some of the meds that you might use. If it's stress related, couldn't we pick putting the person on anti-anxiety medications? Don't think anything bad about it. We all got a lot of stress, right? So if you need those medications to help control your stress in your life because you're having these health symptoms, get on the medications. Take the medications that you need, because this might be life-changing for somebody that has irritable bowel that gets triggered all the time. My son that had the appendix and had the exploratory lap and the 26 staples, he developed irritable bowel after that because his bowel was irritated and infected and had so many issues. So for years and years, he was like, I can't eat that, I can't eat that. This 15-year-old who was normally eating everything now had to modify his diet, and he still does to this day. And knowing that he developed irritable bowel because of everything that happened to his bowel. So sometimes it's not, it's something that we create for the person as well. Most of the time, it's symptom-based. We're going to treat the symptoms. It's okay to give them opioids. It's okay to give them anxiety medications. It's okay to give them Mocamag if they're constipated. It's okay to give them mineral oil if they can't have their to the bathroom. If they have diarrhea, now we put them all on something that's going to slow down the diarrhea. Whatever it is the symptom is, right then, you treat the symptom. You try to eliminate the cause or whatever the trigger is for this person. Is it an acute or chronic thing? It's chronic. The patient has chronic symptoms. It can last for years and years. Patients learn how to try to avoid the things that trigger it and learn how to manage it, but it doesn't always go away. It's usually there. And again, symptom treatment and trigger treatment, basically figuring out what is good for me to eat or not good. Most common digestive disorder seen is irritable bowel. Everybody okay what irritable bowel is, what the symptoms are going to be like. Here's some meds that we might need for that patient. We might not see anything wrong in your endoscopy because there isn't an ulcer. There isn't anything physically that's wrong. We might have an endoscopy and the doctor might say, that's perfectly normal. What do you think that seems like for the patient that has these symptoms? Annoying, irritating, right? Saying, hey, nobody can find anything wrong with me. Okay, this is what I have. We're diagnosing with irritable bowel. So it's more like symptom-based and nothing physically wrong with you that we can find that we can treat, but we're going to treat you with the medication that we're going to treat your symptoms. So again, dairy is a big trigger for somebody with irritable bowel. We don't always tolerate a whole lot of dairy products, cheese, milk, yogurt, whatever. Avoid what it is that is your triggers. Manage your symptoms. Get good nutrition. Try to manage your stress if you can. It all sounds great and easy, but not always possible to do. All right, everybody good with what irritable bowel is? We talked about gastritis already. There's some risk factors for irritable bowel. Usually females, usually high stress, lots of caffeine most of the time in their diet. And again, this is not everybody, but these are the things that we know put you at higher risk for developing this. We see it more in female patients. And usually type A kind of people, more stressful situations, a lot of stress in their life. Oh, I drink a lot of coffee or alcohol or whatever it is. And now again, these are just things that we can recognize in our diet might be the risk factor. No specific test to diagnose, mostly based on signs and symptoms. Okay, so here's what our interventions are going to be. Avoid foods that trigger your symptoms. Avoid dairy. Avoid eggs. Avoid alcohol and caffeine products. Drink a lot of water because you might get diarrhea and be dehydrated. Drink a lot of water because you might develop constipation, so that's going to help you eliminate the constipation in your diet. Increase your fiber intake up to 30 to 40 grams a day. Okay, here's some meds that we can sometimes use. There's a med called Amatiza that we sometimes use. It's an IBS-specific medication, and it helps control the symptoms that the patient has. Okay, everybody okay with irritable bowel? Okay, we gotta keep going. We're gonna take a few minutes break. We're gonna stretch. Yes? Let's just take a couple minutes. You guys walk around. I know it's long, but we gotta keep moving.